in terms of literature, so there are some case series, and two that I'm going to talk about that are from the emergency room, and then two that are actually ophthalmology studies, which are using ophthalmology ultrasound probes, which is different, like we talked about. It's a little stick that actually goes directly on the eye. So I included them because I think that some of the messages they bring out are important, but it's not exactly our emergency literature. So in 2017, the journal Ultrasound of Medicine, they had 3 cases in case series of adults that they had 3 cases of asteroid hylosis, which were actually mistaken for vitreous hemorrhage. These were all confirmed by ophthalmology to be asteroid hylosis and not vitreous hemorrhage. But in the emergency, they were all thought to be vitreous hemorrhage. So this is, in terms of asteroid hylosis, it's usually unilateral, usually they're asymptomatic, and that might help you differentiate what's what. They are both hyperechoic masses and are mobile in the posterior chamber, so it's kind of hard to know who's who. Excuse me. So what you might see, mobile hyperechoic mass made up of multiple points of variable brightness. So again, they talk about the snow globe, and a sparkling appearance of the calcium deposits, which might differ from your vitreous hemorrhage. In terms of differential for vitreous hemorrhage, you always want to think about asteroid hylosis, vitreous hemorrhage, synchesis, skeletons, and vitreitis. There's another case report in CGEM of a 64-year-old female with floaters who again was mistaken for vitreous hemorrhage when she actually had asteroid hylosis. So in in 2004, they looked at the accuracy of an ophthalmology ultrasound using the pen to determine the causes of vitreous hemorrhage. The gold standard was the clinical findings, so either acutely or after resolution, and they were able to look inside. This was a retrospective review of 96 patients, or 106 eyes, with dense vitreous hemorrhages that had A and B scans done by one examiner, and they don't say who the examiner is. So the false positive rate for retinal detachment was 18.9%, but as you can see, the sensitivities and specificities are up there for each type of pathology. So we're actually quite good for retinal detachment. It was actually very good for choroid detachment, not great for retinal tears, and fairly good for foreign bodies. So overall, they thought that ultrasound correctly diagnosed all cases of retinal detachment and poorly performed for retinal tears. They do overdiagnose retinal detachment, so at about 20%. They thought that ultrasound was a good tool for vitreous hemorrhage. So these were where you couldn't see very well into the eye because of the ultrasound. In clinical ophthalmology in 2007, this was again an ophthalmology study, so look at the accuracy of ultrasound diagnosing cases of acute fundus obscuring vitreous hemorrhage. So you couldn't see the fundus because the hemorrhage was so big. And they used a standardized protocol by a dedicated ophthalmologic ultrasonographer. So this is not, again, emergency at all. Prospective, and they all had this hemorrhage of unknown cause. Excuse me. The gold standard was findings during vitrectomy or after spontaneous hemorrhage clearance. Overall, they had 58 patients. So they had 9 retinal detachments and 14 retinal tears. So the complete agreement, they didn't give you all the numbers of who was who. Overall, the agreement was about 80% for completes. The ultrasonographer and the clinical findings were agreeable. 20% had partial agreement, and 3% they didn't know because they were lost to follow-up. So overall, the sensitivity for retinal detachment was good. Questioning, it was hard in terms of their numbers to figure out if sensitivity was good for retinal tears or not. From the other literature, I would say not. So overall, they thought that ultrasound was highly sensitive for finding acute pathology in terms of vitreous hemorrhage. Let's move on to ocular foreign bodies. So again, these are not my pictures. This is courtesy of another one of the physicians. And basically here you're seeing, so orbit, retina, posterior chamber, and then there's something hyperechoic sitting within with reverberation artifacts behind. So you might see a hyperechoic profile of foreign body. It depends on what is the foreign body actually is. You might see acoustic shadowing behind, and you might see reverberation artifacts. You might see none of these things. Typically, your foreign bodies are going to be in the vitreous chamber, but they can be in the retina, they can be in the anterior chamber, and they can be in the posterior to the orbit. This is from a paper by Feldman in 2017 of a case report, 36-year-old male with blood pain after pounding metal objects with a hammer. The POCUS showed a mobile radiolucent hyperechoic structure with reverberation artifact in the posterior chamber, likely to thought that this was a metallic body. And CT did confirm this. So I know this is not all that easy to see. So optic nerve, posterior chamber, and then this is the foreign body right there. You can see the reverberation coming out from behind. And then here is the vitreous hemorrhage. Easier to see in this picture. So metallic foreign body, some reverberation behind, and then vitreous hemorrhage. So in terms of the literature, there are 2 case reports and then 2 studies. So we've already talked about one of the case reports. Patel in 2012 in the European Journal of Ophthalmology looks at the diagnostic accuracy of the clinical exam and radiological imaging for ocular foreign body and open lobe traumatic injury. This is a retrospective review of open lobe traumatic injuries. They had 527 patients with traumatic open lobe injuries, 74 that had surgically corrected intraocular foreign bodies. Mean age was 33, and they did have some kids ranging down to the age of 8. Foreign bodies were all sorts of things, so glass, metal, wood, plastic, and other things. All patients had a clinical exam. They only had ultrasound if they were concerned about posterior segment pathology, and a CT was only performed if orbital fracture was suspected. Overall, most of them were in the posterior segment, but some of them were actually in both segments. Clinical exam identified 45%, ultrasound identified 50%, and CT identified 95%. So overall, they thought that CT was the most reliable for intraocular foreign bodies, regardless of the location within the globe. In Retina in 2015, they determined the imaging features of intraocular foreign bodies and the ability to differentiate the types of intraocular foreign bodies based on the imaging. So they placed 4mm intraocular foreign bodies to cadaver lamb eyes. 6 were metallic, 7 were non-metallic. They x-rayed them, they CT'd them, and they MRI'd them. So x-rayed and CTs had the same set of eyes. Ultrasound had a different set of eyes because they did it on 2 different days. So in terms of the MRI was only done on non-metallic foreign bodies, as that would be a contraindication. So ultrasound was able to detect relatively echogenicity of the object, and they were able to see ring artifact. But there was considerable overlap in the appearance of all the foreign bodies, so it was hard to know what was what, but it did see all of them. X-ray failed to detect certain foreign bodies, so usually the ones that were not metallic had very limited ability to differentiate between most of the intraocular foreign bodies. So overall, X-ray had limited utility. MRI, only on the non-metallic foreign bodies. They did detect them, all of them, but it was challenging in terms of classification. CT actually did very well, and they divided it by what type of attenuation the foreign body gave. And so it detected all of them, and it allowed for their classification. So it was found to be the best modality. And then ultrasound and MRI were thought to be reserved as adjunct as an aid.
So again, this man pushed foreign bodies to a cadaver and then put them in an MRI machine.
Yep.
And he published that.
Yeah.
You see, you could do so many things, Bezo.
So the one case report we haven't talked about is from the Journal of Emergency Medicine in 2009, and this was actually in Iraq, and they had a penetrating trauma after shrapnel from an explosion in an unknown age of a male, where he had decreased visual acuity and a corneal defect with this negative Sedell sign, so they didn't think had a bone rupture. ultrasound was able to show the intraocular forelimb body with probable retinal hemorrhage. Opto exam agreed with this, and the CT also showed a retained foreign body.